Hi, my name is Nate Hanner. This is my video for the substance use disorder paper. Who I have with me right now is my brother-in-law Justin, who is a first-year resident in Hershey's anesthesia program. So I thought this would be a really good person to present this to. He actually went through medical school at Hershey, and like I said, now he's in his first year of residency. He's going to be an anesthesiologist. Doesn't know what he's going to do yet, but he has 3 more years. So like I said, this is the video on the substance use disorder. And the first thing I like to do is just define it. Well, first, let me ask, did you learn anything about this in medical school?
In terms of substance use disorder, we talked about it in medical school. And then as we went off into selecting the specialties that we were going into, some specialties talk about it more than others. And in the orientation for my anesthesia residency, there was actually a specific hour or 2 set aside to talk about some substance abuse issues in anesthesia, but it certainly wasn't a huge topic of conversation during medical school at all.
Okay, and it seems that this is a rising issue in the anesthesia world. So for CRNAs during school, they like to include this as part of our education, and they're trying to make it as a protocol for all CRNA programs. So first, substance use disorder is a disease of the brain characterized by a recurrent use of substances. It could be alcohol, drugs, that cause clinical and functional impairments such as health problems, disability, and failure to meet major responsibilities at work, school, or home as defined in the 5th edition of the Diagnostic and Statistical Manual of Mental Disorders. So there's going to be some other references throughout this interview, so I also wanted to include definition of drug diversion, because that's something that we will see a lot in the anesthesia world because of our access to a lot of controlled substances. So drug diversion is just the transfer of substance from the purpose for which it is intended for an illicit use. So you're basically taking some of the medication that we're giving to the patients, and we're not giving it to them, we're actually giving it to ourselves. Or we keep it for ourselves and take it home. And then another one I wanted to include was impairment, and that's the pending inability to engage safely in the professional and daily life activities as a result of physical, mental, or behavior disorders. So I just wanted to include those briefly before we get started with the major portion of this interview. So before I get into the risk factors, so you've already had about 6 years of medical experience. What would you say would be risk factors for somebody trying to steal drugs at work?
So I think that some contributors would be the stressors of our job. In the operating room, we have a lot of responsibilities taking care of the patient and overseeing their well-being during surgery, so that can lead to lots of stressors at work. A general low self-esteem or feeling just down or depressed could probably contribute to it, which again can go along with stressors, but also things that you don't see at work, such as home life or stressors at home. So I think that depression, low self-esteem, stress at work, stress at home, those sort of things likely contribute to substance use disorders in providers.
Yep, and those are all included. So they have it broken down, so there's some general risk factors like depression or anxiety, maybe a low self-esteem, feelings of resentment, maybe addictive personality or family history of addictive personality. Some behavioral risk factors will be personal use of alcohol and medication, risk-seeking behavior, maladaptive coping strategies, maybe a history of trauma or abuse, or a lack of support system at home. Again, one of the major ones is stress at work, especially for anesthesiologists and CRNA. Working in the OR, we are managing a patient at their most critical moment every single time, especially for anesthesiologists with their critical cases. And minor mistakes with that can lead to a patient harm. So the stress at work is a huge one. Being a victim of bullying and family dysfunction. Another risk factor is somebody who is suffering from chronic pain. Again, working as an anesthesiologist or CRNA, we do have easy access to narcotics and other kind of controlled substances. And at the workplace, again, we have a heightened stress of working in a high intensity environment, which is the OR. We have the production pressure, which means that they want us not only to keep a safe environment in the OR, but they want us to do it as quickly as possible, which normally doesn't really go well together. Trying to speed patients in and out of the OR, but making sure that there's no harm done to the patient. Fatigue and burnout. Me working as a nurse already, I've already experienced this, and Justin going through medical school, I feel like he's already gone through a little bit of burnout and fatigue. The irregular work hours, we can all associate with that working in the medical field. Role strain, inadequate work-life balance, possible lack of education, and substance use disorders. Now, anesthesia specific, a huge risk factor again is the access and availability to opioids, benzos, IV and inhalation anesthetics. And then currently right now it's not really regulated on how we pull and use all these medications, so it's fairly easy for us to divert. So with working in the healthcare, Justin, what symptoms or signs would you want to look for if you thought one of your colleagues was stealing drugs?
So if I thought that, hey you. So if I thought that if I thought that I was noticing one of my colleagues being less engaged in their work on a day-to-day basis, if I noticed that they were being a little bit less concerned about their patient safety and taking kind of poor patient care, that would be something I would look into. But also if I saw them disengaging with me, if I had had a personal relationship with them before, but I started to see them separate themselves, if it seemed as though that they weren't engaging as much with our colleagues, that would be signs of concern for me. There's obviously an importance to having separation from your work and your home life, so I understand sometimes if people don't want to be friends so much outside of the workplace and want to keep that separate, but if it's a big marked change from what they had been doing previously, then I would be a little bit concerned.
Yeah, those are all great examples, and they're all included from my research. So with behaviors, what to look for is like severe mood swings, maybe frequent or unexplained tardiness at work, elaborate excuses. That's something that I see a lot when I was working as a nurse and with nurses abusing medications. Elaborate excuses was something I saw a lot. Difficulty with authority, wearing long sleeves when inappropriate because of the injection in their arms. And then obviously if you see somebody that's confused at work, maybe has memory loss or appears intoxicated, it's another kind of sign that you can see if someone's abusing at work. And that's when someone's abusing it at work, that's usually in the later stages of the addiction because they're a functioning addict, so they're comfortable with actually doing it at work while taking care of patients. Some impairment signs would include physical indications like track marks, bloodshot eyes, deterioration of their personal hygiene, which is something I saw as a nurse, maybe significant weight loss or gain. And unfortunately, sometimes you might walk in and your colleague is unresponsive in the bathroom. Maybe they're dead already because they overdosed, is another sign. Me personally, experience that I saw with some colleagues that was abusing was working a large amount of overtime and then having 2 weeks where they're not showing up to work or they're calling off, a lot. And then they kind of do this cyclic rotation where they just work a lot of overtime and then they call off for 2 weeks because they got all that money and then they're using it to abuse drugs. Certain behaviors to look for is consistency using more drugs for he or she's cases. Maybe they're using too many drugs during their routine cases. Frequently volunteering to administer narcotics when you ask for help. Consistently arriving early, stays late, or volunteers for overtime, like I said earlier. Maybe they require frequent breaks or they are going to the bathroom more often than they should be. Now, with drug diversions from an anesthesia perspective, their record might not match up with what they're dispensing and giving. Maybe your patient will have an unusual amount of pain that is not normal. Is another thing to look for. Inappropriate drug choices and doses for patients, missing medications, and signs of medication tampering, like broken vials that is found in pharmacy.
Mm-hmm.
So I did want to throw an opinion question. So how do you feel about Hershey, let's say we'll go with Hershey, about implementing a random drug screen throughout your entire, like say you stay at Hershey, and as long as you're employed at Hershey, are you okay with them giving you random drug screens whenever they want throughout your whole career? Obviously you'll get one for pre-employment, and then they can also allow you to do a drug screen if they have a cause, so if they think that you're abusing. Are you okay with that?
So Hershey actually does have a policy for anesthesiologists, both attendings and residents, where they are allowed to randomly drug test us whenever they see fit. I don't believe there's a mandatory yearly drug test, but it is written in our contract that should they see fit, they can test us. I think that it's a reasonable policy to have in place, not just so they can catch us and punish us, but also so that they can intervene early if they see fit. I don't think allowing someone to go months and years of abusing drugs, even if they're still performing okay at work, is a good plan. If you have a suspicion early on and you can intervene and help rehabilitate the resident or the physician, it may be something that in the long run actually turns out to be better for that individual than if it's something that was let go for a long time because there was no drug testing policy.
Okay, and I agree with you. I think that they should be able to have the ability to drug test us at any time. We're working in healthcare. We have access to a lot of drugs with the opioid epidemic. I actually do agree and think that they should be able to drug test us whenever. So now we're on. We see signs and symptoms with our colleague. So we visibly see it, and we think that they are abusing drugs. So now we have to go to report them. So if say you see a colleague that you think and you have to report them, why is it so difficult? Why would it be difficult for you? One?
Yeah. So it would be difficult. I think there's a lot of things that go into this question and the reasons why it would be difficult. First off, there's a relatively understood hierarchy in medicine where if I certainly saw a more senior resident or an attending or even a seasoned CRNA abusing drugs, I as a first year resident would have a hard time taking the step from suspecting them to approaching them about it or approaching one of my seniors, just because there is that hierarchy that exists. But at the end of the day, patient care is the most important, and getting help for individuals who have substance use disorders is also important. So that's one thing that would go into it. But another thing is it's such a huge accusation to make that it'd be one that you would feel as though you were officially labeling an individual if you went about reporting it. And I would hate to be wrong in that situation, so I think it would be difficult to take that step without knowing for sure. But again, at the same time, getting early help for the provider as well as ensuring patient safety would be the priority. So I think I would go about it by finding a more senior resident to just discuss my concerns and suspicions with and allow them to help me figure out the best way of going about making a report or getting more information.
And that was a great point with including the hierarchy. I mean, you're at the low, right now you're first year, and I can't imagine trying to approach a more seasoned doctor or even attending if you thought that they were abusing. But other reasons that people have expressed why it's so hard to report a colleague is one, they don't think it's their responsibility. They fear the individual will be punished excessively, like maybe lose your license and get fired. Fear retribution, which you can probably relate to that, especially if it's an attending. Being responsible for the colleague's loss of job or license, or just lack the knowledge of how to approach a colleague who is misusing drugs at work. So once you report, once the patient has been reported, then you have to intervene. And the key thing with providing intervention, it has to be like a safe intervention. You can't surprise them at work. Don't want to have a bunch of people around when you approach them. So they recommend a planned intervention, which is just you assemble an intervention team. You gather all the evidence against them, and then you invite the individual into an interventional meeting. You have to do a drug test at that time, and at that time you also should have a bed ready in a treatment facility. The key thing that they always talk about with the treatment plans with medical personnel abusing drugs is you cannot let them create the treatment plan, because most of these people are going to be physicians, and you're going to have specialized doctors actually create the time for them. So try not to have them individually decide their own treatment. So that's a planned intervention. Sometimes though you're going to have a crisis intervention. That's when they're visibly intoxicated, or you know that they're on some kind of drug at work and they're actually taking care of patients. Then you have to intervene right now. And if they are suicidal or homicidal, so that would be considered crisis intervention. And again, at this point, you cannot let this person out of your sight because they're probably going to flee. Again, you have to get a properly collected drug test, have a trained interventionist, family or spouse, try to get them in as soon as possible. Again, bring all the evidence. Again, you want to have a bed ready in a treatment facility if you can. Unfortunately, it takes time to get a bed available on the spot. And again, you cannot let them decide their treatment. If all this fails and the patient is refusing to get any help, then you might have to contact the police to get involved, do a 301. So the next step would be treatment. Due to the access of controlled substances, obviously anesthesiologists and CRNAs, it's going to be complicated for our treatment plan. So we have unique challenges. So the recommendations from the American Association of Anesthesiologists is to complete at least a 28-day inpatient treatment with a total of 90 days of treatment total. That offers the highest success rate for people to try to get off their addiction. So the ideal treatment center for anesthesia providers include an approval of a state board of nursing. You want to have an evaluation recommendations by the American Society of Addiction Medicine member that is certified by the Board of Addiction Medicine. Then you need to have an evaluation by the American Academy of Addiction Psychiatry board certified psychiatrist, appropriate psychiatric testing, medically supervised detoxification, the emphasis on a 12-step model of abstinence-based recovery, and the evaluation of a suitable for and timing of the return to practice, which is a whole other complication when it comes to being an anesthesiologist or a CRNA. So the last part is where we get the re-entry into the anesthesia arena. So this, again, because of our access, what our job entails, we are at extremely high risk for reusing again. So again, we have a collaborative process when you go back into working at a hospital. So say you're going back to Hershey, there has to be a collaborative process between the monitoring program, a certified drug and alcohol counselor, and the employer. So everybody's working together. And you're looking for at least a minimum of 1 year in recovery before you return to practice, before you're allowed to come back. So the criteria that includes re-entry is evaluation of a licensed provider with experience in treating substance abuse dependency, successful completion of a rehabilitation program, acceptance of a chronic nature of substance use disorder, evidence of supportive spouse or significant other or family. So you need to have support at home, along with having support at your work as well. There can be no untreated psychological comorbidities. You have to have a participation in a monitored program with random drug testing. Again, you need to have supportive colleagues, but not only colleagues, but the administrators and the supervisors. They all need to be very supportive. And you have to be participating in a 12-step program for the addiction. So it's pretty lengthy, it's pretty extensive, but I think it's all because of how of a high risk we are for relapsing.
Yeah, understandably so. I mean, every single day with my fingerprint, I can get into our Pyxis machine and have access to any number of opioids, but not even just opioids, but ketamine and other controlled substances that have a large potential for abuse. And I would imagine that having a background of a substance abuse disorder, trying to get back and handle those drugs on a daily basis would be a difficult thing, having had that in your past. So I imagine that would be a pretty difficult transition to make back into the work field.
So would you say it's a good overview of a substance use disorder? Did it give you a good overview?
Yeah, I think it did. I think there's some definitions in there that were interesting to hear, and then also the conversations that we've had have been largely based in preventing yourself from getting to the burnout stage where you would maybe become at a higher risk for a substance abuse disorder. I haven't heard as much in terms of the intervention, the treatment, and the return to work. So that was all really new to me and interesting to hear.
Okay. Do you have any questions?
Not at the moment, no. I think that summarized it pretty well. Do you think that in your schooling you'll have enough information on preventing substance abuse and preventing burnout?
I think with what was taught in school so far, it's going to make me able to locate and see people maybe at the early stages easier. Preventing burnout, I think that's a tough thing to try to prevent, because I just feel working in the medical field, burnout's inevitable. It's just the proper way to manage being when you're at that point of being burnt out, and knowing that you might have to step away for a little bit, or just having therapeutic responses to being burnt out.
Yep.
So, but yeah, this learning this stuff early on, especially with picking out the signs and symptoms and the risk factors of somebody who could be at risk for diverting or using drugs.
Mm-hmm.
And another thing I learned was I didn't realize how much we have readily available to us and how easy it could possibly be for us to divert.
Yep, I agree.
So that is it for our video. I hope you enjoyed it, and it should be posted here shortly.
Thank you.